So now we're going to talk more about the action potential. And you should have an idea, and there's good tables in the book, the difference between action potential and graded potential. The first thing is the action potential is all or nothing. The graded potential could last longer, right, and continue to get sub-threshold depolarizations. But action potentials already reached the threshold. Remember, it's like flushing the toilet, bullet out of a gun, all or nothing. Once you put enough pressure on that trigger or on that handle on the toilet bowl. So action potential, massive depolarization. And that continues till it reaches that peak. What was it, about 130, 135 positive millivolts, or 40, you'll see. So it's very positive is the key. And in action potential, the depolarization of the membrane has to repolarize. Remember, depolarization is sodium in to the cell. Repolarization is potassium out of the cell based on those channels opening and closing. So again, you have voltage gated channels opening sequentially as the action potential is traveling from the cell body of the neuron, the initial segment, trigger zone, down to the axon terminal. And it's repolarizing as quickly as it's depolarizing. Let's see what's going on here. All or none principle. Let me go back. Where was I? Sorry. I'm not using a mouse because I'm using my writing pen. So we're going to have to look at this again. The RMP. And I know it's a lot of repetitive stuff, but it's really important to get this. The resting membrane potential, right? Minus 70 millivolts on a neuron, right? Where it's not excited yet, but it's ready to be excited, right? So if you get depolarization stimulus and you get above the threshold, which is minus 55, then you'll get your action potential along that axon of that neuron. So you should be familiar with all the parts of the neuron, of course. And depolarization, sodium entering voltage-gated sodium channels, because you need channels. Right, here's the channel, membrane channel. So when the sodium comes in, it depolarizes the membrane. So the minus 70 will get more positive, hopefully to minus 55 to create an action potential. Right? So again, same thing. Go through these pictures, whatever helps you. So, and it's happening along the membrane, traveling along the membrane, going to the actual axon terminal, because that's where the neurotransmitter is released, right? Remember the acetylcholine in the muscle. But now it could be any neurotransmitter. It doesn't have to just be acetylcholine, because we're talking about the nervous system now, right? So again, talking about depolarization. Channels for potassium diffusing out. We'll start now repolarization. These are the steps in repolarization. So they stay open for a longer time because you have to repolarize the membrane, and sometimes that takes a little bit longer. And I mentioned what hyperpolarization is, when maybe too much potassium leaves the cell. So the cell membrane will go to minus 80, say, or minus 90 even. So once that membrane gets that hyperpolarized, it's harder to get another action potential. Does that make sense? And sometimes that's appropriate. Sometimes you want to hyperpolarize a membrane. I think last time we were talking about anxiety and GABA and glutamate, and how the membranes, if they're hyperpolarized, then that's inhibiting an action potential. And we need that sometimes. Not so much in muscle, but in your brain, right? And you see, people seem to really understand that pretty well, which is really good. So once the RMP, resting membrane potential, is reached, then we don't need to take potassium out of the cell anymore. And we could settle down at that minus 70, waiting for another impulse, whether it be from another neuron or from the brain, like the cerebral cortex, for a actual voluntary somatic contraction of a skeletal muscle, maybe. So this is a great picture right here from your book. I'm looking at this because I like what it does. So here's your RMP. I know this is repetitive, but why not? Here's your resting membrane potential of a neuron membrane. So now you're going to get stimuli. Remember Hussein wearing his underwear or not? And you get graded potentials that are sub-threshold. And this can go on all day. This can go on all day until it reaches the minus 55. Right? So once there's enough stimulation, enough stimulus from wherever it's coming from a neuron or from your brain or from Hussein's underwear, then that could depolarize and that sodium's coming in, right? So it's traveling up to the peak of the action potential, which is plus 30 millivolts. Then you have to, because this is an action potential. So this has to repolarize. It can't stay up there because that would be completely inappropriate. And then it'll go down in repolarization. And repolarization, the sodium channels close and the potassium channels open. So all these terms really important. And you learned this already when you struggled through that hard muscle chapter. But now you're going to see how you're going to know it well. Now, if too much potassium comes out of the cell, you might have this dip to plus 80 or plus 90, and that's hyperpolarization. Right? And that's what we talked about with inhibition. It's going to inhibit an action potential. And a lot of postsynaptic membranes have these inhibitory postsynaptic potentials, IPSPs, graded potentials. So then everything closes and it's back to RMP. The potassium stops coming in. So here's the deal. Know your resting membrane potential, minus 70. Know the difference between graded potentials and action potentials. Know the threshold for an action potential, minus 55, which is less negative than minus 70, the RMP. Know that depolarization is infiltration, influx of sodium into the cell. So the sodium channels are open. Potassium channels are closed at this point, or they're very slowly opening. The peak of an action potential is plus 30 millivolts. So that has to repolarize. So repolarization is sodium channels closed, so it can't come back into the cell. But more importantly, potassium effluxes, leaves the cell. So that's potassium efflux. For repolarization, depolarization, sodium influx. I know we did this before, but why not? Okay, now it's the whole idea of getting potassium out in the sodium potassium ATPase pumps is to get back to a resting membrane potential. But sometimes you get too much potassium out, or sometimes, like again, potassium out in high levels, or you might get chloride, which is a negative ion, in, and that makes it even more hyperpolarized. So that has to do with hyperpolarization, not just repolarization. Chloride doesn't have anything to do with repolarization most of the time, well, at least for our purposes. So you really have to understand this page. I really like this page. And all the pages before build up to this. It's a difficult topic. Okay, refractory period I mentioned. And refractory is a period when no matter how much stimuli you get, how strong the stimuli is, you're not going to get another action potential. So that's the period of absolute refractory, where there's no way, no how, probably because it's hyperpolarized or it's still repolarizing. Right? So absolute refractory, and it's really important to have this because think about this in the heart. If your heart receives a stimulus where it's not supposed to, it can cause tetanus of your heart, and that's why that's important. It's not so important for skeletal muscle or what we talked about already, but the absolute refractory period has to be adhered to in that membrane potential, or else you're going to have a problem with your heart. Relative refractory, you might be able to get another action potential if the stimulus is great enough or you have a high number of stimuli, right? So you can get that. So that is like where cell is just slightly hyperpolarized from the threshold. So let's say it's minus 75, right, which is slightly hyperpolarized. Technically, that's a period of refraction. But if you have a stimulus that's strong enough, you'll get another action potential. So refractory is disallowing an action potential because of the hyperpolarization of the membrane. Absolute, no way, no how. Relative, if you get a strong enough stimulus, you can get a action potential. And that's what I need you to know about refractory, especially when you go into AMP2 with the cardio, if they go that far. So you've seen this before, so practice it. Practice it. Know this chart. It answers a lot of questions. Or this table, whatever you want to call it. So continuous versus saltatory. Now we're getting back to easy stuff. You know, continuous is without myelin, without the Schwann cells and the oligodendrocytes. Saltatory is with the Schwann cells, the myelin. So continuous is unmyelinated, and saltatory is with myelin. And you know that myelinated fibers produce the conduction faster, more organized, where continuous is a little slower. So again, this is pretty simple. This is just talking about the conduction of depolarization traveling over the Schwann cells or over the myelin and getting to the axon terminals faster. Right? That's all that's saltatory. Saltatory or saltatorization means jumping or leaping from node of Ranvier to node of Ranvier. So again, like the conduction, again, we don't have to memorize this. I mean, this is just showing you. This is unmyelinated and the time it's going to take. This is myelinated, where the impulses jump. They don't really jump. They kind of travel across and go to node, to node, to node, to node. So they kind of skip axon geography, right? Right? They kind of skip that. They jump over that. Where this has to travel down the axon, it's going to take longer, milliseconds longer, but that could be important, right? If you have a demyelinating disease, and you or even have diabetes or something where your nerve vessels are destroyed, but if you have a demyelinating disease like ALS or multiple sclerosis, and you step on a nail or something, it's going to take you longer to react to that. Or you're stepping on a hot surface, the reflex is going to be affected because it's going to take longer, and milliseconds can mean tissue damage. Yeah. So this is something that we've been through already, the transmissive segment, or what happens at the synaptic knob. Right? So don't get caught up in the jargon up there with conductive transmissive, because you already know this. You know what happens. So now the synaptic knob is the axon terminal, right? And the key to that area is opening the voltage-gated calcium channels. So calcium can come into the cell at the synaptic knob. And what does that do? Right here. So calcium coming into the synaptic terminal are going to bind to vesicles. What's in the vesicles? What's in them? Neurotransmitters, like acetylcholine. It could be other neurotransmitters. We're going to talk about other neurotransmitters today. So then the neurotransmitter could be released from the synaptic end bulb or the synaptic knob, same thing, and then flood the synaptic cleft to the postsynaptic membrane, which is probably another neuron, because we already talked about muscle being the postsynaptic membrane. So when the calcium gets into the the presynaptic synaptic knob, is the best way to say it, or synaptic terminal or axon terminal, and the vesicles will fuse to the membrane, and the neurotransmitter is released through exocytosis. And then the neurotransmitter can bind to its specific receptor on the postsynaptic membrane, the next neuron. So the neurons are what is synthesizing the neurotransmitter. Would it be? It could be epinephrine, it could be dopamine, it could be serotonin, it could be acetylcholine. Okay, it could be GABA, it could be glutamate, all those neurotransmitters that you probably heard of. Okay, and of course it's dependent on the action potential that reached the synaptic knob or synaptic terminal. Excuse me. So here's how your book draws it out, which is pretty good, I guess. So here's your presynaptic neuron. It already received the stimulus, maybe from another neuron, right? And like we learned in muscle, maybe from the cerebral cortex, because it's a voluntary motor response. Voluntary, came from your cerebrum, your brain. Cool. So once that action potential reaches the synaptic end bulb, which is this whole big bulby thing, the calcium channels open. The calcium channels open. Calcium floods the cytoplasm of the neuron. Now look what they're showing us here. They're going back to the last test, the neuromuscular junction. So this should really sound familiar. So what happens when the calcium enters the cell? These voltage-gated calcium channels are open due to the action potential. It's going to fuse with these little spaceships, these vesicles. Sometimes they're called synaptic vesicles. And the vesicles will kind of bind to the membrane of the presynaptic neuron and expel that neurotransmitter into the synaptic cleft, which is all this. And the neurotransmitter is going to diffuse to the other side and bind to its specific receptor. The neurotransmitter doesn't go into the cell. So these are the receptors for the neurotransmitter on the postsynaptic membrane. Look at this membrane. You've seen this a million times. Biphospholipid layer, right? So a protein is going to have trouble getting in because it's lipid mostly. I hate to throw that at you, but it has nothing to do with the neurotransmitter. But some chemicals, like when you learn hormones, like testosterone, could walk right in because it's a lipid, right? It could walk right in and do its job. But something like epinephrine has to bind to the receptor, then a bunch of other stuff happens because it depends on what the hormone is made of. But this happens to be a neurotransmitter, which will never enter the cell. This is a neurotransmitter, not a hormone. So I just want to bring that up now. So the neurotransmitter binds to the receptor and then opens up this channel. And guess what's coming in now? Sodium. And you can get potassium to go out as well through the same channel, but we're depolarizing now. So that means sodium in. And this is the neuromuscular junction. So you know all about this. You know what's going to happen next. You're going to get a muscle action potential. And then the sarcoplasmic reticulum is going to release calcium, and calcium is going to bind to troponin and displace the tropomyosin, so you're going to get a muscle contraction. Of course, in the presence of ATP, right? And oxygen, if it's there, right? So that's really important. So let me get in your face now. Wake up now. Wake up, everyone, because I'm recording. I want to make sure you get this. So who could tell me what exactly is going on here? Let's start it this way. We can talk about muscle contraction, but know this. The postsynaptic membrane is usually a neuron, not the muscle, in other things we need to talk about. But how do we get an action potential in the presynaptic neuron? What could be a stimulus? Any neuron. It doesn't have to be that somatic motor neuron. What do you need? That's a tough question, but what do you think? Go ahead. Rosemary, what do you say?
A stimulus?
Yeah, you need a stimulus. Like,
it's anything essentially like responsiveness, maybe? You know how they say responsiveness, like if you get a or like, I don't know, if you
it could be, yeah, like it could be a sensory neuron too. Like you said, you could have a receptor for something like pain that is stimulated by a nail or touch. You know, it could be anything that creates an action potential in that presynaptic neuron. That's exactly right. So then that presynaptic neuron is going to depolarize segment at a time to threshold. So before you step on the nail, or before you decide to move a muscle, what's the number of the resting membrane potential? Do you remember, Kimber? Like, what's that number in millivolts? And you don't have to give me the exact number.
Resting 55. Right.
Minus 70, right?
Yes.
Yeah, like minus 70, or you know, anywhere in that range, you know. Like, and we're talking about neurons now, so that's very good. So what's the threshold for an action potential? What's the number that as
55.
yeah, minus 55. So you get enough sodium in through depolarization and you reach minus 55, then you can get an action potential along that axon. Very good. Now, what do we call the potentials that are constantly stimulating the membrane but never reaches the threshold? That's not an action potential, but a what? Like Hussein's underwear. It's not action potential, but a what potential?
A resting membrane potential?
No, graded potential.
Okay.
Yeah, sorry, I kind of asked that question kind of weird. So graded potential may go on for a while and never really have an action potential. That's very good. So now if we get an action potential, then it's going to reach the synaptic end bulb, which is the same thing as a synaptic terminal, right? So what voltage gated channels open in the synaptic terminal? For what ion?
Potassium?
Potassium.
No, at the synaptic terminals. Now we're going to where the neurotransmitters are stored.
Is it sodium?
No, not yet. Not yet. What's the other? That's one more left now. Not chloride, but what's the ion that has to come into the synaptic end bulb to bind to the neurotransmitter vesicles?
Calcium.
Calcium. Very good. Very calcium. So this is really important. Calcium is extremely important in nerve conduction for this reason. Yes, very good. So now if calcium can come into those channels after the action potential reached the synaptic end bulb, then those vesicles that are filled with neurotransmitters can go towards the membrane of the presynaptic neuron and then release the neurotransmitter into the synaptic cleft through exocytosis. Right? So what's the neurotransmitter that's used for muscle contraction? What's it called? Begins with an A.
ACH.
ACH, yeah. Acetylcholine. Acetylcholine or acetylcholine, however you want to say it, or ACH is fine. So excellent. So that's the neurotransmitter for muscle contraction that's going to reach the receptors on the muscle membrane. But we use it in the nervous system a lot too, especially for parasympathetic stimulation to the effectors. Very good. But it could have been epinephrine as a neurotransmitter. It could have been serotonin.
I said GABA.
Could be GABA. Yeah, it could be glutamate. And if there's a receptor on the postsynaptic membrane, it's going to bind with it because it has to be very specific. You need the specific receptor for each neurotransmitter. So here's a really tough question now. Who's ready for this? Renee, are you ready? Let's say on the postsynaptic membrane, and this is where Dion was going, I think. If on the postsynaptic membrane, you have receptors for GABA. GABA. You got to remember what I said last time. So is that going to be an inhibitory postsynaptic potential or an excitatory postsynaptic potential in the brain, an IPSP or an EPSP? Take a guess. I don't care if you're wrong.
Inhibitory.
Inhibitory, that's right.
Yeah, it wouldn't get excited.
That's right, because GABA binds to a postsynaptic receptor, its postsynaptic receptor. It's not going to allow sodium in. It's going to allow chloride in or potassium out, which is going to hyperpolarize the membrane. So that would be an inhibitory postsynaptic potential. So that next neuron is going to receive a graded potential that'll never reach threshold, and you won't get an action potential. But I'll tell you this, acetylcholine for muscle is always excitatory, but in the parasympathetic, sometimes it's inhibitory. All right, and we're going to have to revisit that. Let's just see where we're going at this point to the next topic here. So this is another thing you already learned in a muscle. You struggled through that. It was hard, but you made it, and now you're going to understand the nervous system a little bit more, which is excellent. And then when you do cardio next semester, you'll understand that a little bit better. All right, so here's a nice little breakdown of graded potentials versus action potentials. You're almost there. You almost get this already, right? So again, things like traveling short distance with a graded potential. Let's get some keywords for you here. Again, they're both through gated channels. They can be positive or negative, which means it could be inhibitory, IPSP, or excitatory, EPSP. And of course, they're graded, right? There can be many graded potentials or one consistent neuron firing the stimulus over and over. So they could take longer, but they travel a shorter distance. That's the best, basically, a breakdown of graded. Action potentials occur, and these are always excitatory. It's always from a depolarization. So they move along regions of the axon with voltage-gated channels, and it's always sodium in, and they always have to repolarize. The graded potentials never really have to repolarize because they never reached an action potential. Or if they did, it's no longer a graded potential. Now it's an action potential. And action potentials are all or none, like flushing the toilet, right? Graded potentials can go on all day, like Hussein's underwear. An action potential will propagate, it has to propagate all the way down from the initial segment or trigger zone to the synaptic knob where the neurotransmitters are stored. And that's where the synaptic knob is where the calcium, voltage-gated calcium channels are. So remember calcium at the synaptic knob. So the speed, of course, and I mentioned this before, not that hard of a concept, the thickness or the diameter of the axon and how much myelination it has on it. And technically, the longer an axon is, the longer it takes. So the length of the axon does matter too. So thicker, more channels being opened. And of course, if it's myelinated, it happens faster. I don't think that's a tough concept there. Right? And it's saltatory, right? That should tell you this is saltatory conduction with myelination. Very fast, very fast. So you have it jumping over and going through. It's very fast. And I think that's the concept. Don't worry about these numbers, just an idea. Just an idea how fast they're going. But very is good enough for me. And you, believe me. Okay. Basically saying the same thing over and over. Let's see if there's anything more. So here we go. We're going to talk about neurotransmitters specifically now and what they are and what they're made of. So this is kind of important because after we do neuro, we're going to talk about hormones. And hormones are chemically similar to neurotransmitters, but it's more important what they're made of when you talk about hormones than it is about neurotransmitters. But know this, both of them are chemical messengers that ultimately are going to create a change, right? So again, I bring that up because you're going to have to understand that question when we do neuro in a couple of weeks or 3 weeks, whatever it is. Not neuro, endocrine, sorry. Okay? So let's start talking about neurotransmitters. I like talking about neurotransmitters. I like to ask questions about neurotransmitters. So these are the chemical messengers that are released into the synaptic clefts, not into the blood, right? That's another key. Neurotransmitters are released from presynaptic neurons from their synaptic end bulbs into the synaptic cleft to reach, and it doesn't have to go to another neuron. It can go to an effector like skeletal muscle, cardiac muscle, glands, and smooth muscle that you see in blood vessels or in the tubes of digestive system or tubes of respiratory system or reproductive system. So acetylcholine you've heard of, right? Acetylcholine, all right? That's a fairly large neurotransmitter and it's different than others, right? So you can't consider this a protein or lipid, right? So it's acetylcholine, acetate and choline. So it's kind of a mid-size neurotransmitter. Then you have the biogenic amines. Now stay with me here. Biogenic, that's not a scary word, just, biology. Amines has to do with proteins, right? Amino acids. So these are your protein-based neurotransmitters. Like, I'm going to use the term catecholamine sometimes. I'll never really say the word indolamines. But catecholamines, again, make these neurotransmitters like dopamine, but also, I don't know why it's not saying here, but epinephrine. And for a neurotransmitter, I like to use norepinephrine more. It's just a slight chemical difference because it's more common in the synapses, norepinephrine. So that's a catecholamine. And so they're going to have specific receptors. They're kind of similar, like dopamine receptors are kind of similar to norepinephrine, but believe me, they don't bind the same neuron, same receptor, but they're very similar. And they're based on an amino acid called tyrosine. So norepinephrine is based on this tyrosine, dopamine is based on tyrosine, where serotonin is made from a different neurotransmitter called tryptophan. So I do like you to know those amino acids that are the base molecule for these biogenic amines like norepinephrine. I'm going to talk about a lot. Dopamine, I'll talk about a bit. And serotonin, I'll talk about a little. Okay. So some are purely amino acids, right, where they don't have any other functional groups on them. So examples of neurotransmitters that are just amino acids are glutamate. Remember, glutamate is in the brain is the most excitatory neurotransmitters for EPSPs. But in special sense, it's actually inhibitory. So when you do special senses in lab, like you'll do the eye next semester, glutamate may confuse you. You say, oh, Fenicio said that was the most excitatory neurotransmitter in the brain. It is. But when it comes to special senses like vision, hearing, taste, glutamate is more inhibitory. And I can't explain why. But in the brain, it's extremely excitatory. Glycine is the most these are all inhibitory right here. No, I'm sorry. These two are inhibitory. Glycine is inhibitory, especially in the spinal cord. So glycine is more about opening the channels for chloride, which would be inhibitory, right? Because that'll make the membrane potential even less negative, hyperpolarizing it. GABA is the most inhibitory neurotransmitter in the brain, gamma aminobutyric acid, almost purely just an amino acid, very small, right? Then we have these other neurotransmitters, which I'm not sure if they're really 100% neurotransmitters, but they do bind to receptors on neurons. And these are called neuropeptides. And peptides has to do with proteins as well. So that's why chains of amino acids are employed here. So you can hear something called endorphin and substance P. So get this, right? Substance P is a chemical released when you have tissue damage or you underwent some trauma. Inflammation maybe will release this as well. So substance P will bind to a receptor and give your brain the cognition of pain. So substance P elicits the pain cognition. An endorphin is an endogenous opiate or opioid that's released from our brains. And endorphins block substance P. And both of them are neuropeptides. So when substance P is released into the synapses, endorphins are released from the brain to block substance P as a pain reliever, because you can't go around in pain all the time. Of course, this doesn't work 100% of the time. Depends on how bad the tissue damage is. So again, some of them are excitatory. Depends on what they do. Like if an excitatory neurotransmitter at the postsynaptic membrane always cause EPSPs if they're summated to EPS to action potential. So excitatory neurotransmitters are going to open sodium channels and cause depolarization, where inhibitory neurotransmitters that cause inhibitory postsynaptic potentials are going to hyperpolarize the postsynaptic membrane, so you can't get an action potential. Hence, they're inhibitory. And that's why GABA is inhibitory. That's why glycine is inhibitory. And in the brain, again, neurotransmitter could be used differently in other parts of the body. So very careful when I say the brain with glutamate and GABA. Glycine in the spinal cord is inhibitory. Acetylcholine to the muscle is excitatory. Epinephrine to the heart, blood vessels, and glands is excitatory. But epinephrine to the digestive tubes is inhibitory. Remember me eating my my burrito in Central Park, and the bear comes out to get me. Right? He wants to have me as a burrito. So I'm going to release epinephrine from my synapses immediately, and epinephrine is going to excite my blood vessels and makes them contract to elevate my blood pressure. It's going to excite my heart, my SA node, and cause my heart to beat faster. But epinephrine, when it reaches my intestinal tubes or my stomach, it's going to inhibit, because epinephrine sympathetic stimulation doesn't care about digestion. It wants me to either run away from the bear or fight him, fight or flight. Epinephrine sympathetic. So of course the choice is clear. I'm going to run away or lay under the bench and cry. Right? So action, is it direct?
Professor?
Yes. Go ahead. I'm listening. What's up?
Sorry to interrupt you.
Not at
but-
all.
So then if that, can you hear me?
Yeah, I can hear you.
Okay. I'm sorry for interrupting, but
Not at all.
I have a question about that. So if your endorphins kick in, how does adrenaline come into play? Because I know people say, like, if they get into a crazy accident or like if they get shot, they have like a shock, like a shock period where they won't feel the pain. So is that like endorphins and adrenaline working together, or do the endorphins go first and then the adrenaline is what gets attached to the postsynaptic?
Well, when we do endocrine, we're going to talk about that exact topic. But just let me give you the difference between the nervous system response to stress. It's really stress response, or shock, as you say, and the difference between a neurotransmitter and then a hormone. The nervous system acts very fast, so you're going to get those immediate responses. And norepinephrine is the same as adrenaline. It's the same thing. Just there's a neurotransmitter, epinephrine, and there's a hormone, epinephrine. The difference between the neurotransmitter and the hormone, the neurotransmitter is released in your synapses to your nerve tissue, your neurons. The hormone, epinephrine, which is also known as adrenaline, is released into your blood. So hormones act very slow compared to the nervous system. So yes, you know when you're in sympathetic stimulation, you don't feel anything. And does it have anything to do with endorphins? Yes, it could have an endorphin response quick, but it's not really about pain, because you might not cognate that pain for minutes after. So when you're in that epinephrine release, and yeah, you can do miraculous things like lift a car off an old lady under a tire. You could find your fog lights on your car faster than you could if you weren't under sympathetic stimulation. You might think a little clearer for a few seconds. It's completely appropriate. So that's basically how it works. And I just want to clear up that epinephrine and adrenaline chemically are basically the same thing. But we're talking about the nervous system. So we're talking about lightning fast delivery of that neurotransmitter to the receptor, and then the outcome is fast. Like for my heart to start beating faster through the nervous system, it's a split second. But now, again, remember me with the burrito in the park. Once the bear is gone, I'm going back to my burrito, right? My nervous system calmed everything down, but I still have adrenaline in my blood to slow response, adrenaline. So my heart's still going to kind of be beating pretty strong for another 20 minutes or so, depending, of course, on your own heart and your sympathetic nervous system. So that initial response, epinephrine release, fight or flight, can cause you not to feel any pain. It could be, it's appropriate, but it could be dangerous, right? It could make you react a lot faster. And of course, epinephrine is released in your brain as well. So you think a lot quicker, and your blood flow to your muscles is faster, and your blood flow to your brain cells is faster. Does that make sense?
Yeah.
So epinephrine, but remember what I said. My point of that whole thing was epinephrine is completely excitatory to my heart, right? My blood vessels, some of my glands, but it's completely inhibitory to my digestive system. And the point is that epinephrine is not always excitatory. It depends on what the effector is. And that's sympathetic, which is really another takeaway you should have. That's a sympathetic response. Cool? Make sense? So direct or indirect, I'm, again, this is about the receptors. This is about the receptors, right? And most neurotransmitters have to bind through chemically gated. If the acetylcholine binds, then the sodium channels will open. And sometimes it's indirect, and which sounds crazy because I'm saying how fast this is, but when epinephrine, which is remember it's a bioamine, a biogenic amine, will bind to its receptor, and then there has to have a couple of other things have to happen before you make the change. And I'm not going to talk too much about G protein receptors until we get to endocrine, and unless we get a nice picture of it, then I'll kind of talk about it. But I'm talking about the nervous system and endocrine system because they work very intimately together. So hormones are in the blood. Endocrine means into the blood. But hormones have to bind to receptors, just like neurotransmitters have to bind to receptors. So sometimes the neurotransmitter can make a direct change. Sometimes it has to make an indirect change by affecting what's called G proteins and a second messenger. And I would say in all the nervous system, second messengers are cyclic AMP, sometimes cyclic GMP. AMP is adenosine monophosphate, so we get that from ATP. So just want to say this on the recording so you have an idea of where this is going. So indirect receptors are usually G protein coupled receptors. So you need different proteins to make a change by activating a second messenger. This is a really complicated thing. So a lot of neurotransmitters do their job through this indirect pathway. It's called transduction. But direct is usually something that's like acetylcholines. Direct opens up the channel on contact to its receptor. And you're going to learn about lipid versus protein hormones. Lipids get into the cell membrane a lot faster than proteins do because of the lipid, biphospholipid layer is mostly lipid. So that whole hydrophilic thing that I made such a big deal out of, and polar versus non-polar, is going to come back to us now. And I'll explain it again when we get there. So it does affect neurotransmitters as well. So I always like these because it kind of breaks things down based on chemical structures, right? And the biogenic amines, which you saw, and the amino acids, the GABA and the glutamate, the neuropeptides like endorphins, substance P, right? Biogenic amines were your epinephrine, dopamine, serotonin. So go back and look at those, and then you have the effects of the neurotransmitters on the postsynaptic membrane, whether it's excitatory, EPSP, or inhibitory. Direct or indirect, this is the hard part. Direct or indirect. So for now, just remember the indirect need G proteins to activate a second messenger, which most of the time is cyclic AMP. Cyclic adenosine monophosphate. So let's go through.
Professor,
yes.
this is where that magical potion of an EpiPen comes into take place, right? When someone has a reaction to like maybe peanut allergy or a drug overdose.
That's a hormone, though. It's technically a hormone, but it's the same thing. It's the same chemical
Oh,
structure.
the
Like
EpiPen doesn't
EpiPen is a
stimulate all
human.
these. I'm
What is
sorry.
that, Hussein? I'm sorry.
Doesn't the EpiPen stimulate whatever is going wrong due to these allergy reactions or drug reactions?
Well, this is what happens. Let's clear this up now, which is a great question. So, you know, if you're allergic to something, anything like legumes, you know, peanuts, whatever, and your body's going to cause a severe reaction to it it's an immune response because you're hypersensitive to that antigen, which is the chemicals that are in legumes, say, or anything. It could be any bee sting or anything like that. So the chemicals, just like a neurotransmitter or a hormone, but it's your body thinks it's completely foreign. So it's going to react by opening up your blood vessels, and the blood vessels dilate, severely dilate. All the chemicals that cause vasodilation respond to this antigen that you're allergic to and cause massive vasodilation. Peripheral, not just in one area. So when your blood vessels dilate so much and become heavily permeable, it drops your blood pressure severe. Like your normal blood pressure could be 120/80. But if you introduce this antigen from the peanuts or whatever, your blood pressure is going to drop severely, like from 120/80 to say 60/20. You hear me? That's called anaphylactic shock. So your body's in shock. And if you have no blood pressure or that low blood pressure, you can't get cardiac output. You can't get oxygenated blood to your brain. So down you go, right? Down you go. You're off your feet. You're bellied up, right? So then, you know, this person knew they were allergic to peanuts, but somehow the street vendor threw a peanut in something, and you happen to see his bracelet, and you see in his pocket he has an epinephrine pen, and it's epinephrine. It's adrenaline. It's the same thing. So once you stab him with the needle, it's usually intramuscular, right, Hussein? Put it in the shoulder or the thigh. That epinephrine is going to permeate into the blood of that person, and epinephrine, as a hormone or a neurotransmitter, is going to bind to its receptor, and it's going to cause his blood vessels to constrict. So it's the opposite of anaphylactic shock. Now he's getting vasoconstriction, and that's going to raise his blood pressure or her blood pressure back up to at least 90/80, maybe 90/60, whatever gets the blood back to their brain before they have ischemia to the brain, which is lack of oxygen for more than 10 minutes. So epinephrine causes a peripheral systemic vasoconstriction because it stimulates the smooth muscle in all of his blood vessels to contract, thereby increasing his blood pressure. And at the same time, increases his heart rate by increasing action potentials in the SA node of the heart. So hopefully the EpiPen is going to get him out of that anaphylactic shock and get oxygen back to his brain or her brain. Does that make sense? Yes?
Yep.
So you're introducing excitatory neurotransmitter, we'll say now, and it could be a hormone too, that is excitatory to blood vessel walls, which are smooth muscle, tunica medius. Hopefully you learned, because you didn't learn that yet. That's in the second semester. But smooth muscle is involuntary, right? Smooth muscle is in the walls of your blood vessels and in the walls of your digestive tubes too. So the EpiPen that you stab them with is going to cause relaxation in the digestive tubes, reproductive tubes, and more vasoconstriction of the air tubes, your respiratory tubes. So it causes bronchodilation, so you can breathe better too, epinephrine. So that kind of makes sense. That's really important. Actually, what I just said was very important, and it was a great question. So people kind of know what a EpiPen is, and it's epinephrine. It's adrenaline. It's the same thing. Is it a hormone or a neurotransmitter? It doesn't matter. It really doesn't matter because it's going to affect both. So I hope that's clear. So let's take them up one by one. I'll give you the highlights. Like acetylcholine is probably the most abundant neurotransmitter in your body. Like if you saw it on the ground, you would walk right by. You wouldn't even pick it up. At the dollar store, you probably would pay a penny for it. Right. So again, acetylcholine is very important. It's somatic muscle contraction. Somatic nervous system. I went through the effectors for the somatic nervous system versus autonomic, because autonomic is fight or flight and rest and digest, parasympathetic and sympathetic. So acetylcholine gets involved in both of those too, by the way, which is, I'm not going there right now. So again, it's synthesized by acetate and choline. And where's it stored? In the synaptic end bulbs. Yeah. And you know about action potential. You know about calcium channels open. Don't forget that. Right? And the acetylcholine attaches to its specific receptor. And how does it leave the synaptic cleft? It's degraded by an enzyme called acetylcholinesterase. You know all this. And then the acetate, the byproducts or the breakdown products are sold off at a garage sale and stored and then used to make more acetylcholine. So they're recycled. Now this is getting into something that's really kind of difficult. So I'm gonna introduce this now. Now it doesn't say here, I can't see it on this page, but this is very important. The receptors for acetylcholine are called cholinergic receptors. You're gonna have to memorize this, so I'm recording this, so please pay attention when you go back. Cholinergic receptors have two types. There's nicotinic and muscarinic. So nicotinic are basically always excitatory. You ever hear of nicotine? You know that stuff they put in your vape or your, you smoke your cigarettes and chew your tobacco, you get that nicotine. It's always a stimulant to your blood vessels and your heart. So, but this is an acetylcholine receptor. So you have nicotinic and then you have muscarinic. Muscarinic could be either excitatory or inhibitory. So if you're listening, these are all about autonomic pathways. Autonomic is parasympathetic and sympathetic. Sympathetic is fight or flight, and parasympathetic is rest and digest. But I'm only talking about acetylcholine here. So these receptors, especially this one, nicotinic, is used in all autonomic pathways. So you're going to have preganglionic neurons and postganglionic autonomic neurons. So when you hear muscarinic and nicotinic, it's only receptors for acetylcholine. Let me just see what I just did. So that's really important. Just to know, my point is that you should know that all receptors for acetylcholine are cholinergic. That's really important. Let's see if I can get back now. Kind of get lost there. Tough topic. So again, that's going to have to be some memorization. And then if we get to the autonomic nervous system, which probably won't get to the whole thing, but we talk a lot about autonomic, right? Every time I mention the bear or epinephrine, that is autonomic response, rest and digest versus fight or flight. Of course, fight or flight is sympathetic. So this is a good point here. How is the neurotransmitter removed from a synaptic cleft? We already know about enzymes because we learned about acetylcholine being degraded by acetylcholinesterase, which is an enzyme. Sometimes a neurotransmitter will go through what's called reuptake. So that presynaptic neuron and its end bulb will take back the neurotransmitter. All right. So that's called reuptake. Like serotonin, serotonin, right? is a neurotransmitter, and it is released in your synapse. And if it's decreased, right, if you have decreased serotonin in your brain synapses, you tend to go through depression, maybe manic depression. So you have low serotonin, right? So you have low serotonin, and that could equal depression, like psychological depression. But depression, I can spell this right. So it's psychological depression, but it's biological, because the problem is biological, because this biogenic amine is in low abundance. So this is a biology, it's a chemical problem, depression. It's not just a psychological thing. Well, there was no sun today, so I'm not feeling so happy. No, it's much more than that. You have low serotonin. So you give somebody an SSRI, as a doctor, selective serotonin reuptake inhibitors. So the drug is an SSRI, like I really don't know everyone, but maybe Prozac, right? So Prozac is an SSRI, a selective serotonin reuptake inhibitor. So it's going to inhibit the reuptake and keep the synaptic clefts flooded with serotonin. Okay, so that's, it makes sense when you talk about the chemical that stops it. So some neurotransmitters are taken back up into the presynaptic envelopes. Some just diffuse away through diffusion, right? Some are reabsorbed by the glial cells like a microglial cell, right? Which is like the garbage man of the CNS. Right, like they're talking about SSRIs here, right? Selective serotonin reuptake inhibitor, like Prozac. Elavil maybe is another one. And then you have acetylcholinesterase inhibitors, which I probably mentioned before. So acetylcholinesterase inhibitors is a good medication to give somebody with like myasthenia gravis, right? And it has been known to treat the mild cognitive impairment of dementia, like Alzheimer's disease. So if because acetylcholine is also excitatory in the brain, it helps get the synapses to get memories formed, especially short-term memory. So if you stop the degradation of acetylcholine, you might have a little more short-term memory, or you might be able to contract muscles better with MG. So you're inhibiting the enzyme acetylcholinesterase. But again, all these drugs have side effects, because it's not just affecting one part of your body like the brain, right? Because both of these are talking about the brain. But MG is not just in the brain, it's from the CNS, but it affects the muscles. And as you learned in the other exam, myasthenia gravis was an autoimmune condition that destroyed the receptors for acetylcholine on the muscle end plate. So that's really, really important. And here you go. You got the same thing. You should know this by heart. The only thing it's not showing you is the calcium channels, the voltage-gated calcium channels here, opening to allow the acetylcholine to be released into the synaptic cleft. Let's see. Now we're talking about another neuron. It's not the muscle anymore. Right? And you can see there's a receptor called the nicotinic receptor in this case. And nicotinic is always for acetylcholine. And here's a muscarinic, which is usually on the effector. So muscarinic is also a cholinergic receptor, only for acetylcholine. But here, look what you have. And see if you remember what I said before. This is difficult, really. So like this receptor is direct receptor. It affects, once acetylcholine binds to this cholinergic receptor, which happens to be nicotinic, you're opening up a sodium channel. Right, so it's always stimulatory. And it happens to be direct. Right, it happens to be direct. And they're mentioning curare, which maybe we'll talk about later, like in the jungle, when somebody had to throw a blow dart at you, they would block these receptors to stop your transmission of acetylcholine and depolarization, so you drop out, right? A blow dart uses curare. So they affect those nicotinic receptors. Right? And then you have an indirect receptor here, which this one happens to be muscarinic. So acetylcholine binds to the indirect receptor, which is a G protein coupled receptor that activates a second messenger, which is always cyclic AMP, and that will cause further depolarization. Oh, it depends on the effector, though. Depends on the effector. So these, like atropine, is another chemical, like curare, that stops depolarization. So atropine. I believe they use that when they dilate your eyes, your pupils. When you go to the eye doctor, they use atropine because it relaxes your iris muscles. So your eyes will dilate, your pupils will dilate, so they can look in and see your retina with the ophthalmoscope and all that. So atropine and curare basically block acetylcholine receptors. So you got to get this whole receptor thing down. Neuromodulators are cool too. Neuromodulators, and technically I put like neuromodulators. This is what I said before, like something like an endorphin or substance P, technically is not exactly like the other neurotransmitters. So it's more of a neuromodulator. Like substance P will give you the consciousness of pain, and endorphins will block the substance P. So some things facilitate and some things inhibit, and that's all this is really saying. So it depends on the chemical. I like to talk about these. These are pretty interesting. What do they call them? Neuromodulation. So these are two good ones. All right. Let's see. I can't get this thing to move. I don't know why. So nitric oxide, not nitrous oxide. That's not nitrous oxide. The stuff, the laughing gas that the dentist gives you before he rips out your teeth. Right. Nitric oxide is actually released from cells, blood vessels, endothelium, actually. And nitric oxide, I'll tell you right now, let me just see, and I'll just write it right here, causes vasodilation. So it can lower your blood pressure and increase blood flow. Let's write that. It'll lower your systemic blood pressure and increase blood flow, which is a nice combination, right? And this is released locally by the cells themselves. And it's a gas, and it's very short-lived. NO, right? NO, just NO, not NO2, which is nitrous oxide. NO is nitric oxide. I'm not saying no like negative. That's the chemical symbol of that molecule, a molecular symbol. Okay, so it's released by neurons, right? Where you're going to need some dilation in the blood vessels, right? So it's affecting the blood vessels. So nitric oxide. So let's talk about this. This is an interesting one. Renee, you with me on this? So, like say in the heart, right? Everybody know the heart, that thing in your chest, right? It beats, but it's a muscle too. So it needs a constant flow of oxygen. Constant flow of oxygen. Because without oxygen, you can't make ATP. And if you don't have, and we learned this last time, or 2 times ago, who knows? If you don't have oxygen, you're not going to be able to make ATP. And then if you don't have ATP, your muscles can't contract. And your heart, like I said, your skeletal muscle, you know, we could run around and run a mile and then rest and pay back that oxygen debt. It's like using a credit card. You buy now and pay later. But in a heart muscle, it's cash only. You know, you have, if you stop the oxygen, or you consume all the oxygen, or you lose all the oxygen, your heart's going to stop beating, and you're not going to get any blood to your brain. If you get no blood or oxygen to your brain, you're going to become a carrot basically in 10 minutes, right? So oxygen is extremely important in our tissues. I think we're learning that now, and you don't have to have AMP2 to learn that. You know you need oxygen to your tissues, or else they're going to become necrotic. They're going to die, right? So your cells of your heart are so concerned about oxygen getting there or not getting there that they could release this chemical called nitric oxide that increases your blood vessel lumens, increases blood flow by vasodilation. which kind of lowers your blood pressure overall, but increases blood flow to the tissue. Are you following me? Because why is blood flow to the tissue so important? Because it's got oxygen in it. Red blood cells carry oxygen. So nitric oxide will allow that to happen. So did you ever hear of erectile dysfunction?
Yep, all the time.
You heard of that? I
Lots
never
of
heard of that.
commercials.
I just heard about this like last week.
If
Erectile dysfunction.
someone you know suffers from.
Say what? Suffers from. Yes. Does anyone you know suffer from that? Right.
Yeah.
So anyway, you know, they were doing research on this nitric oxide, right? Nitric oxide for blood pressure. They were trying to control people's blood pressure, but there was a problem. There was like a side effect, and the side effect was an erection, right? In the male, of course. And then all of a sudden, it really wasn't that helpful for controlling. This nitric oxide wasn't as helpful as they thought for controlling your systemic blood pressure, but it worked as a treatment for erectile dysfunction. So what do they call that? Viagra, right? Not Prozac, Viagra. Viagra helps to release nitric oxide to get better blood flow to the reproductive organs in the male, right? So that's vasodilation is the key. Now let's see what they have to say about it.
What does that have to do with oxygen and erectile dysfunction? Like, is there more oxygen pumping blood to the?
Oh no, we'll talk about reproductive, but it's really about getting oxygen to the erectile tissue. It's not muscle. Yeah, that's a good question. Yeah, it's erectile tissue. It's like expandable tissue, you know, that needs blood supply to do its job and to fill with blood. And yeah, it's a great question because it's not contracting. Nothing's contracting. So we'll go into that, the corpus spongiosum and the corpus cavernosum of the penis. And that's basically erectile tissue. It's like elastic tissue more than it is muscle. Excellent question. But it needs oxygen to do that. It needs the flow of oxygen. Yeah, very good. That's really important. Excellent point. But we'll talk about that in reproductive a little bit. I'm not going to go too far into that. I think it's more important now to talk about the nitric oxide than it is in reproductive. And you'll understand it when we talk about it, if we talk about anything extensive as far as erectile dysfunction. So endocannabinoids, right? CBD, the cannabinoids, right? We make those. I mean, endo means we make them. They're made inside our brain, actually. So they have these endocannabinoids are neuromodulators. They bind to a receptor, right? They may influence memory, I don't think on a positive note, maybe even a negative memory issue, right? But they have effects on postsynaptic membrane. So there's a lot of research as far as endocannabinoids being used. But I think it's pretty positive, you know, as far as treating anxiety. Like I'm sure you all might know somebody who has a medical marijuana card, right, to enhance their neuromodulators of CBD, right? So it can help with anxiety. It helps with certain pain. It's been shown clinically to help people who have inflammatory bowel diseases like Crohn's disease, ulcerative colitis, the symptoms. But it's not curing anything except for maybe it's thwarting seizures. So there's a lot of positive research about endocannabinoids and CBD and the different receptors. That there's really only 9 receptors that they know of as of last year. But maybe this year, as the research continues, they can find different receptors at different outcomes. Because of course you got to test this on other mammals and see how they react to things like pain and maybe even addiction. Like if you're addicted to nicotine, some endocannabinoids can help with kind of taking away some of the side effects from withdrawal from something like nicotine or worse from alcohol, right? Alcohol withdrawals, maybe even opioid withdrawal. So it's positive that way. I don't know actually smoking it and using those chemicals, or not chemicals, they're pretty much all natural, but using those outside, or they're not endocannabinoids because they're coming from outside your body. So I don't know what the long-term effective your memory will be, but I'd be concerned about it.
I have a question.
Yeah.
So what about CBD? You know how people use like CBD for like pain, because it doesn't have the THC in it. So if people use
Yeah.
that for like, for example, like for like headaches, right? They
Yeah.
have like these creams that you can rub on your temples. Is that
Sure,
gonna
sure.
do anything? Or
Personally, what I think, and I'm pretty much involved with all this stuff, I think it's a huge marketing plan to make money.
Mhm.
That's my first thought. It's like kind of exploiting that it can do, have some calming effects, like you said, like the rubby-dubby, some CBD on an ankle sprain, or if you have muscle spasm or shingles, even, it does have a temporary effect. But is it the miracle that everybody's selling it for, trying to make money off it? No, absolutely
I
not.
agree
Not
with you,
yet.
Professor. There's a lot of interest group out there to make money off that.
Yeah, I think so. I think that's always my first thing. A friend of mine at the university that I teach at is he's one of the world-renowned researchers in Canada in CBD, and he has no confidence until he sees something that is useful. But he's hopeful. He's hopeful. Renee, you have a question?
I did.
Go ahead. Shoot.
So you know how Rosemary asked about CBD?
Yeah.
So the law says like you can get a medical marijuana card if you suffer from like PTSD,
Yeah.
or like other problems. My question is, do you have to see a doctor and request it, or you can just kind of do something like that on your own? And if that is true,
Oh,
medical marijuana then has THC in it, no? It's just like a certain amount.
yeah, it can. Yeah, it can, which is kind of like, makes you high, right?
Yeah,
Makes you
so
high. Yeah, that's not the point, though. I mean, most people get the card because they want to get high, but I'm not talking about that. So again, THC, but THC can have positive effects too, but of course it has terrible side effects.
right, so why would you want to give it to people?
Well, mostly for the CBD effect, and the CBD doesn't have THC in it. So medical marijuana is a pure form of it, and again, it depends on your state who's allowing it to be used as a medical treatment. I don't think they're clear with what exactly is the outcome of
Actually,
THC.
some CBDs actually
Do you
do
know
have.
what's in it? Like the medical marijuana, is it THC or is it CBD?
Mostly
Or
CBD. Oh, it's CBD. Yeah, it's mostly CBD. Like you said, that's exactly what it is.
Professor,
Yeah.
because I actually sell CBD, so in my job, so
Leandro, it's for your job, right? Because you know this is recorded, right?
no, there's nothing illegal about it. They have New York State limit of 0.03%, so it's like
Thank you. I didn't know that exact number. That's pretty good. Yeah.
yeah, it's New York State limit. So some CBD
Yeah.
products like Charlotte's Web will carry that percent from
Yeah.
New York State limit in order to sell it.
Yeah. So there's a lot of like different state laws, but I think it's going in a good direction. I like the fact, not personal for the personal reasons, but I like the fact that they're decriminalizing it a bit, for what you're carrying, because the point that I'm making is like, why could I go buy, a handle of Tito's and can't walk around the streets with that, and you can't carry, a dime bag of marijuana or whatever the law is, right, Leandro? It's an ounce. I think you can get away with an ounce, and they don't decrypt, because you're gonna have to go for a job someday, right? And what if that's on your record of carrying, not illegal? It's illegal. And from what I hear, Leandro might be able to tell you, but just because they're legalizing it doesn't stop the black market. Because if I want to start a marijuana dispensary, you're going to be so overridden by governmental laws that you're not going to be able to make any money anyway. So you might as well just sell it on the street because you're going to make more money, which is why it's going to be a bigger problem if they're not careful. But I don't make those rules. I don't know. I just know it's a chemical, and and you have to smoke it, right? And I don't agree with any smoking, or else I'd be smoking it myself, maybe. Who knows? Instead of having a margarita. I don't know.
Well, I'm pretty sure any type of smoke within the lungs restricts blood vessels throughout the body.
Yeah.
So
And it's got to be some type of effect. You know, like, did you ever hear of digitalis? Hussein, you probably heard of this. Probably your patients take digitalis. Like we talked about beta blockers, right? Once before, maybe. So if you're taking digitalis, is a completely natural drug, but it affects the contraction of your heart. It makes your heart contract a lot. But you could die from taking digitalis if you take it in the wrong doses, right? So it just because it's natural doesn't mean it's healthy, or it's not going to cause a side effect, right? So natural is good. I mean, again, you're worried about taking vaccines that are synthetic and have other additives in them, but like cigarettes, of course, or vaping. So, but marijuana, at least they're controlling it to get it as natural as possible, so it doesn't hurt you in other ways. So some people it really helps, like I said, seizures, gastrointestinal issues, children, even children, babies. All right, so the research is still going on. So, but it's all based on endocannabinoids, which are made by your brain, my brain, everybody's brain. But the receptors, right? Here's another key: like the receptors have to be affected here. Like if your receptors are proteins, right? All the time they're proteins, and proteins have to be transcribed from your DNA. So genetically, you might not make enough receptors. So you could have chemical issues making receptors, genetic issues making receptors, where you're not able to bind endocannabinoids. So for what works for me might not work for somebody else genetically.
Professor,
Yes.
if I take an endocannabinoid,
Well, you don't have to say endo because that's in your body.
so if I take a
No, that's not your fault. I probably should have made that. CBD is the cannabinoid part.
because we already have it in. Endo means in.
You
If
got
I
it.
cannabinoid, right?
Mm-hmm.
Or menstrual cramps, they're severe. I can't. I'm dying in class right now. You probably just can't see.
Yeah.
But if I were to take that medically, does that do anything with me in my mind to say I'm restricting something from inside my body to control the pain, or is it just like some psychological thing because I'm smoking?
You know what? I would say it's both, and if it works, more power to you. Any drug that you take, you have to weigh out the benefit over the risk. If you're, if my cramps are horrible, it stops my day, and I can't even, concentrate, then it might be worth it to try something natural like a CBD to control it. But you have to be aware of any side effects. Now, I'm a placebo guy. So if you gave me a Tic Tac and you told me there was CBD in it, and I was having a menstrual period or cramps or anything, I shouldn't say that, like say a headache or a tension, I bet you the placebo would help me. The Tic Tac would help me because I'm thinking I'm having a CBD pill. You know what I mean?
So, Professor, are you saying like taking something like Tylenol, Motrin, or such would have that same effect? Because
Different.
they're not really healers; they constrict pain, correct?
Yeah. Well, no, not. Well, Tylenol has a little bit of an effect on substance P, but an Advil is purely anti-inflammatory, and sometimes inflammation gives you pain. So I think when you take an anti-inflammatory like Advil, naproxen, ibuprofen is what that is, or naproxen, you're actually treating the cause in a way. You're getting rid of the inflammation, which hopefully they'll come out with an anti-inflammatory that's not going to destroy your stomach like an Advil.
Well, naproxen definitely destroys my stomach. It's hardened my stomach over time. So I was told to not take it, to take like ibuprofen. But ibuprofen 200 is nothing.
It might be better.
Yeah.
Yeah. No, I agree. But so I mean, it's great because most of the inflammation, most of the problems we have, and like heart disease, dementia, is inflammation. It's caused from inflammation, and these are anti-inflammatories. Like again, the menstrual cramps, prostaglandins you'll hear about when we talk about endocrine. They create inflammation, which is completely appropriate at first, but it creates pain, and it can create, like I said, heart disease, Alzheimer's disease, So we need to find an anti-inflammatory very similar to Advil that's not going to destroy your stomach.
Professor,
Yeah.
there's some natural alternatives to fighting inflammation within the body. There's the plant turmeric.
Turmeric's okay. Yeah, turmeric's okay. If you're Indian, they eat that stuff all the time. It's a proven natural anti-inflammatory.
Also, the
Disgusting. And you can't take too much of it because if your body doesn't break it down properly. So you have to know.
Yeah, yeah. I've seen autopsy brains where the people who use turmeric their whole life, their brains turn orange, but it didn't hurt them. I mean, it didn't hurt them. Yeah, you can't have a problem with your kidneys or your liver if you overdo natural things. So, but if turmeric was going to be the anti-inflammatory, it didn't happen.
Yeah.
You know,
Also,
the thing they're going to have to break down these flavonoids like vitamin B3, vitamin B5, the niacin, the nicotinic acids, and the riboflavin. Once they isolate that, then you're going to have a good natural response to inflammation.
yeah, I had a
Right
customer.
now we don't have it.
I had a customer that had a spinal surgery, and she was young too. I think she was like 32. So she was doing her research, and she actually took a Japanese enzyme called serrapeptase that helps fight inflammation. And she said after a few months of taking it, she had no back pain after taking.
Yeah, but that's one trial. I mean,
yeah, of course.
You know, the way these trials work out, you have to, you could treat, first of all, you have to test it in animals, and that could take 10 to 15 years. And then you have to get a small population of people, like you said, like whatever, 30 people. And then you have to put into clinical trials, and that takes 30,000 people to get an outcome before you could say that even if it's an all natural substance, is going to work. So anybody could, anecdotally talk about, something working, but is it going to work for, percent of a population?
There's my question. You said that they would have to trial a couple of people in certain groups, right?
Yeah.
I'm just gonna stretch before I reach and ask you, do you trust the COVID-19 vaccine? Because you said that they have to test it on multiple people before.
Yeah, and different cultural groups, different parts of the world, it's got to be tested. Do I trust it now? I think you're asking me if I trust the NIH, and basically you have to. What else do we have?
Didn't they test it, the vaccine? Didn't they test it in South Africa?
Yeah, they did it just very, very quickly, right?
I mean, the sample was not as big as we would like, but given the issue we have at hand,
yeah,
you got to take the good with the bad. I mean, it's not the perfect study that they've done, but
it's not too bad though.
A lot of people, sure.
I'll tell you what's unfair. Like back in heart disease, right? Back in the 50s, that's when they realized that, well, maybe if I eat too much fat or I smoke or I don't exercise, it's going to affect my heart, right? But now we know all that, right? But in the 50s, there's this place in Massachusetts called Framingham did a study. It's called the Framingham study, and they're still doing it. But it started out in the 50s, and this was a bad time. People, they didn't even care who you were. All they tested was white males. So they didn't test females, right? So now if you notice that the incidence of heart disease is increasing in women, it's not because it was never there. It's because they never tested that population. It was a biased study, right, Renee? Right? So you not only do you have to test 30,000 people, you have to test 30,000 diverse groups of people that may live in different places, right? I mean, for me to be satisfied with it. But if you have a global pandemic like polio, you're going to be testing this stuff all over the world, not just China, hopefully, Russia, but in the United States and New Zealand, which hardly has the virus, So you have to take those studies with a grain of salt too. So let alone somebody blogging on Instagram about, using ascorbic acid in great doses to treat heart disease or something, right?
I took the vaccine, so if you don't hear from me, then
Who said that?
Yeah. So most of us are waiting for other people to get the vaccine, right, Joe? Now you're one of
I think
those.
about 3 million New Yorkers took it already, so I think that's.
Yeah, I read that.
Joe,
So far, so good.
okay.
But now you know what you're going to hear now. You're going to hear like somebody somebody who had the vaccine got COVID, got
But
COVID.
Professor, with that whole vaccine, I don't know if you heard this, but they're saying that you might need to retake it every 6 months.
6 months? I heard that.
Yeah.
I did hear that. Yeah, I did hear that.
That's kind
Sounds
of
like a
crazy.
moneymaker to me.
Of course.
That's interesting because I thought that even though we take the vaccine, we can still get it. It's just not going to affect us as much as it would if we didn't have it.
Yeah,
Like,
you won't
wouldn't
get
be
the
deadly.
symptoms as fast.
It's a rarity that they're saying, Rosemary. It's not, I mean, it's the percentages, what they're saying is the percentage is going to be, it's not impossible, but it's highly unlikely.
Yeah, no, I mean, the global pandemic, man. We're living through one. So let's.
Oh, well, yeah. I mean, I
We're
work
part of
with
history.
contact tracing, and I've known a couple people already that have gotten the vaccine, and then they're like, "Yeah, I just got it," even though it wasn't after the 2
They
weeks.
tested positive. They tested positive.
Yeah, but it's because it takes about 2 weeks for it to take.
Yeah, I would stretch that to 3 weeks if you're gonna go see grandma.
Yeah, so it takes about 2 weeks, but a couple of people will be like, "Yeah, I got it on Sunday, and I tested positive on Wednesday."
Yeah, that you're gonna hear. I wouldn't be worried about that right now.
Yeah, I
3
think
weeks
it could have
after
been that you could have been a carrier before you got the vaccine and you just
That's
know about
possible. Yeah, you could have been positive. Yeah, and or tested positive. Then you don't know. That's good. Good points. Good points. You guys are on your game. Too bad you can't tell me what muscle contraction is, though.
it. We'll get there. If it was on the news every 5 seconds, we would probably know.
That's right. I should send you TikTok videos every other
Why
day.
not? I think that's a good way of
I
studying.
think it's a great way. I think you're right. I think you're absolutely right. Okay, neuronal
Now,
pools.
whatever you make on TikTok video, make sure it's on the test.
Yeah, that's right. That's
Or
right.
you do TikTok video?
I don't.
Why not? I think you
I
should
just like
create an
saying
account
TikTok.
today.
Yeah.
He probably has one already.
I just like saying TikTok. I've seen them and sometimes they're really hilarious, actually. Okay, so let's go on. Let's move on a little bit. We'll take a break. Let's see. So these are cool. These are neuron circuits. So this is like these electrical circuits. And I'll point out the ones you need to know. Again, we're still recording, so make sure you listen to this. I know we go off the topic a little bit, but you know what? It's a Sunday, every Sunday we're going through this, so no point in just dragging you through physiology all the time. We got to talk about other things that are relevant. So converging and diverging, we'll take a picture of that and you'll get a picture of that, and reverberating, parallel after discharge. They're cool names, right? So this is a converging circuit. So you're getting input into one specific neuron that could be going to the cerebral cortex, right? So multiple sensations like salivary. I'm eating my burrito. I'm smelling things. I'm smelling the nuts roasting over on the cart. I could hear somebody playing some cool jazz in the background, and it's going to create a memory and get a converged circuit into my cerebral cortex and maybe parts of the brain that store memories. So that's kind of cool. Then you have like one neuron that has multiple connections, right? And this is more motor, because you have one input coming from the brain for me to walk on a balance beam in the park. Then I have to pretty much recruit other parts of my brain to help me balance. So this is more motor, I would think, diverging circuits, but know what they look like, and see if I can get you some questions that make this simple. Reverberating circuits, again, this is a little bit more autonomic, right? Where you have kind of connections feeding back into one circuit. Like say this is one circuit, and then you have like a different group of neurons adding to that one circuit. Like you ever play chess or something sometimes, and parallel after discharge as well, but like they could reverberate back, may affect your memory and your reactions to certain things. So this is a reverberating input coming in from back, and they kind of see how it's kind of going up and around, and could have something to do with a little bit of your short-term memory as well, but also autonomic, right? Getting us breathing and not overinflating our lungs. And again, we're not going to do respiratory here. So I just need you to know the different types of circuits. We're not going to see every circuit, of course. Now, this is a really, mathematical, this one here called the parallel after discharge. And you probably use this one to play chess too. So this is a parallel after discharge. It's all going in one direction, if you notice, to get one output, one decision. You know, so, but this is more, I would say this one is more mathematical, you know, higher level thinking, higher order. They called it higher order thinking. All right, so all good. Anybody have any questions so far? We finished that's a big chapter. We talk about a lot of things in that chapter. So I'm going to go on to the brain. What time do we get out of here? 2:50?
Yes, yes.
2:50?
Mm-hmm.
So let's take 20 minutes, or what time is it now? 1:45. We don't have a lot of time. Okay, so come back at 2:05. How about that?
All right, thanks. Yes.
Is that cool? 2:05. Go stretch out, get something to eat, smoke them if you got them. Some Tito's. Roll it up, go to it. Whatever you guys do on your
Oh, God.
So now we're into the CNS, specifically with the brain. Remember, the CNS, central nervous system, is the brain and the spinal cord. So you're going to learn the brain parts in the lab. So I'll go through that and just draw it out for you, so you have an idea of some of the physiology, at least today. And then we can finish this up after the exam if we need to. So the largest part of the brain is called the cerebrum. And I mentioned the cerebrum when I talked about the cerebral cortex, right? The cortex is the outer part. Cortex means bark or outside. And the cerebrum has left and right hemispheres. And you're learning the bones of the skull, which you learned already. Basically, they protect the skull bones, cranial bones will protect the same lobes of the brain that they're named after. Like there's a frontal lobe of the cerebrum. There's 2 temporal lobes of the cerebrum. There's 2 parietal lobes and 1 occipital lobe. So those pretty much cover the whole cerebrum. There's no sphenoid lobe. There's something called the insula, which is like more or less the 5th lobe, if you will. We can mention that. Then the deeper brain, an older brain, is the diencephalon. So let's draw it out, because this is a really important part. There's the most important part to me is of the diencephalon is a place called the hypothalamus. Now this is not where we do any thinking. This is all autonomic, homeostatic. Right? We think with our cerebrum lobes, cortexes. Another part of the diencephalon is the thalamus. And that has a lot to do with sensory information, except for smell. It's a relay station for sensory. And then there's the epithalamus, which could have something to do with smell, but also has an extension of it, a gland. An endocrine gland is not nerve tissue. Like the pineal gland is a gland off of the epithalamus. And the pineal gland secretes a hormone called melatonin, which is about your circadian rhythm, sleep-wake cycles. Hypothalamus also has a neuroendocrine connection with the pituitary gland, which we'll talk a lot about when we get to endocrine. So the pituitary gland and the pineal gland are not nerve tissue, they're endocrine tissue, making and secreting hormones. The brainstem is even older part of the brain. Of course, we don't think with our brainstem. And the 3 parts of the brainstem are the midbrain, the pons, and the medulla oblongata. We'll go through some of the functions of those parts of the brain. The medulla oblongata is probably the second most homeostatic part of your brain. Of course, the part that doesn't do the thinking, autonomic function. Cerebellum has a lot to do with balance, motor balance, muscle balance, equilibrium, along with your cranial nerves too. Balance, I'll put equilibrium, but motor, muscle contraction. No cognitive cortex in the cerebellum. The cerebellum could store some muscle memory, like when you're learning how to do a dance or hit a golf ball, play a cello, things that you don't consciously have to think about when you're doing those motions. And we'll find out what gyri means, and they're like the hills of the cerebrum, and you have sulci, which are more depressions or valleys. So just some words to remember, like you might have heard anterior is the same as ventral, but in the brain, they call it rostral. I'm not going to really ask you a lot of questions about rostral and caudal, but you should know posterior, like towards the tail, is caudal, because we're bipeds, right? Most mammals are quadrupeds, so their brains are kind of horizontal, where ours are more vertical, towards our vertebrae. So it tends to go caudally. Where in a quadruped, it still goes caudally, but it doesn't go inferior. It goes more horizontal towards the back of the mammal. So here is a left lateral view of the brain. And again, you can't see all the parts, but you certainly see the cerebrum. And these hills are called gyrus, or gyri is plural. It's gyrus. So get these down. And the little valleys in between all of them are called sulcus or sulci. So sulci is plural. Usually Latin words have an I at the end being plural. It's kind of reverse of the English. So you have frontal lobe. This is the left frontal lobe because we're looking at the left side. And then you have the parietal lobe. And this is really important. The parietal lobes, really, and the frontal lobes are separated by a sulcus called the central sulcus. This is really important that you know central sulcus. Sometimes it's hard to tell where that is unless you have, like in the lab, you might get pictures where these two gyri are different colors. That helps. So I'm going to tell you the names of those gyri and what they do, just so you have this now. So in the frontal lobe, the anterior gyrus, all of this is called the precentral gyrus. And the precentral gyrus is all about your motor function. So technically, it's the primary motor area, especially the cortex. So this is the area, the precentral gyrus is the area where I voluntarily start a muscle contraction. It's all about motor. And it's on the frontal lobe, right? Because it's anterior to the central sulcus. And again, in lab, you might see some different colors. So the one behind, posterior, on the parietal lobe, the gyrus, is called the postcentral gyrus. And this is your primary somatomotor area. I'm sorry, somatosensory, sorry. Somatosensory. And the cortex will cognate what we feel, like stepping on a nail or a tickle or some light touch, crude touch. So this is sensory, postcentral gyrus, and that's parietal lobe. Where the precentral gyrus is frontal lobe. So right now you're thinking, yeah, it's true. The frontal lobe has more to do with motor, voluntary motor. The parietal lobe behind the central sulcus, especially that postcentral gyrus, that one gyrus, has more to do with sensory information. So sensory input, right? Afferent information coming in from the PNS to the CNS, where the motor gyrus, also known as the precentral gyrus, is descending efferent neurons going from the CNS to the PNS ultimately. Excellent. So here's the occipital lobe. And the occipital lobe kind of does what it sounds like it does. It's involved in cognating vision, what we see, what colors we see. A lot of circuitry going to and from the occipital lobe. It takes up like 30, I would say, no, maybe more like, 30% of our brain circuitry is involved with vision, very specialized function, special sense of vision. It starts really in the retina of the eye. And then you have a temporal lobe. Temporal lobe looks like a boxer's glove, thumb, right? So temporal lobe, you're going to see, has more to do with olfaction, which is smell, like knowing what you smell. Our brain has a lot to do with olfaction. It goes back years of olfaction, smell, before we develop the higher levels of thinking, vision, and other faculties. And also hearing, temporal lobe. Now there's a lobe you're going to see that's kind of deep to these areas, and it's kind of behind these. You'll see it in another picture, and that's called the insula. So the insula is like another lobe, like the fifth beetle, another lobe that you can't see on the external surface, but it's deep. And the insula is about memory, has some memory, like of things like smell, like olfaction is smell.
Can I interject?
Yes.
All right, so the insula looks like it's right, sorry. Because at the top, there's a lateral sulcus, and then
Good call. Very good. That's exactly where it is, but it's deep. Like I would have to cut the tissue out to see it. I just wanted you to be aware of it.
Mm-hmm.
And it's exactly where it is. So kind of like it's behind the frontal and parietal and temporal lobe, right by that sulcus. You're exactly right. So the lateral sulcus separates the frontal and parietal lobes from the temporal. Very good. That's exactly where it is. And the insula also, that memory of olfaction could be related to disgust, like something is not so pleasant. There's been some research on the insula. So we don't know as much about the insula as we do about the other lobes. But again, still under research. So most textbooks don't even mention it 10, 15 years ago, which really isn't that long. So that's the cerebrum. That's the largest part. And that's where you see the obvious gyrus and sulci, gyri and sulci. And then you see other parts that we mentioned, like you can't see the diencephalon because that's deep. We're going to have to look at a mid-sagittal view to see the diencephalon. You don't see any of it from here. So the next thing, and don't confuse the cerebellum with the occipital lobe of the cerebrum. Cerebellum looks a little different, and it's, of course, inferior to the cerebrum. So the cerebellum is more, like you said, about balance and motor. Maybe have some muscle memory. Now here's the brain stem, and you can't see the midbrain. That's up behind the temporal lobe, like below the insula, I guess. But you need a mid-sagittal view. So the brain stem has the midbrain, but also the pons, which is another word for pons is bridge. So it bridges the circuitry between, let's say, the cerebellum and the cerebral cortex, or the medulla oblongata, which is here. And this is where you have a lot of your cranial nerves off the brainstem. I think 10 of them are actually off of the brainstem. They are. And the olfactory nerve and the optic nerve are cranial nerves that are not off of the brainstem. The nuclei is not in the brainstem. And then the spinal cord starts here. So remember the big hole in the skull, the foramen magnum? Well, basically, above the foramen magnum, you have the medulla oblongata. Below the foramen magnum, you have the spinal cord. And that's still CNS, right? Spinal cord is still central nervous system. And the nerves will emanate from the spinal cord. Spinal nerves will emanate from the spinal cord between each vertebrae that you learned. Cervical, lumbar, thoracic, right? Cervical top, thoracic in the middle, lumbar on the bottom, and sacrum and coccyx. So yeah, the lateral sulcus, of course, you should see what that is. So, I won't ask you much about that, but lab you might have to know. that are practical. There's a parieto-occipital sulcus. But this one for lecture is very important because of these two, the precentral gyrus and the postcentral gyrus. Because precentral is all about volition, voluntary muscle control through the nervous system. Postcentral gyrus is about cognition, of realizing what you sense or feel, right? Mostly somatic senses like pain, touch, temperature, tickle, crude touch, fine touch, vibration. Not so much the special senses. This is an inferior view of the brain. And again, you in lab, you're going to go through the cranial nerves, like naming them, which I'm not going to really put a lot of time into because you have to learn the physiology in lecture. So this is the anterior, right? Anterior is here where your eyes are. That's good. It shows you where the eyes are. Then you have your optic nerve here, which is cranial nerve 1. I'm sorry, your olfactory nerve, which is cranial nerve 1. You always have to write the nerves in Roman numerals. Like cranial nerve 1 is olfactory nerve, and that's way up in the frontal lobe, above your nose, right? Remember, we learned the cribriform plate of the ethmoid bone in lab. So there's foramina for these olfactory receptors that will send information to the olfactory bulbs, and then the olfactory tracts will take it back to the temporal lobe, cerebral cortex, or the temporal lobe for cognating what you're smelling. These are the optic nerves. Question?
Your olfactory nerves, is that where you have like basically your sense of smell? So if we were to meet in class and every day you wore like YSL cologne, at some point I'm gonna tap into that. So when I go somewhere and I smell YSL, I'm gonna think of you, right?
Yeah, not so much because of the, that's a good question. Not so much because of the optic nerve, but remember those circuits, Renee, like we were showing you?
Yeah.
There's a connection to memory. And for some reason, through evolution, we have a lot of memory based on smell. You know, for smell, for some reason. I think our old brains have a lot to do with smell. So some of the other mammals like sheep and canines, dogs and cats, they rely a lot on smell because they don't talk probably. So once we develop talking, like our memories kind of changed a little bit. But the olfactory nerve, like what I'm talking about now, is it's kind of nuts and bolts. It's kind of just, you know, a circuit. It doesn't have any other function besides to take that chemical that you smell, whether it be like a, you know, they cut up an animal to make this perfume or cologne, and you're going to bring that smell into your temporal lobe to say, okay, that smells like this. And then your memory is going to get involved, like you just said. You say, well, I remember, you know, my professor had that cologne on when he was teaching me how to use a microscope. And that when next time I smell it, it reminds me of using a microscope. So the olfactory nerve itself is just the wiring to bring it to the temporal lobe, but the brain circuits create that memory. And if, let's say, Finizio smelled really bad, no matter how handsome he is, he still smells pretty bad. So you're going to remember that. So if you're sitting in a room and, you know, they're showing you pictures of different professors you had, and then all of a sudden Finizio comes up and you remember that smell, you're going to be a little disgusted, even though he is a handsome guy. Your insula is going to kind of light up and get activated for that reminder of that smell. So it could be good, could be bad, right? Depends on how your brain processes it and what you relate that memory to. You know, that cologne that Finizio wearing could have been a cologne of somebody you didn't like years ago, and that could remind you of that. And kind of your circuits get kind of crossed with that memory, which could have been good with the guy who taught you how to use the microscope, but could be bad for the guy that, you know, hit your car or ran you over on your bicycle. So that's a good question.
Professor, are these figures going to be on the exam?
No, definitely not. Yeah, I'm not going to put pictures up because I'll save that for lab. Yeah, you're gonna do a lot of this in lab. So just kind of go with me with olfactory means smell so far. I mentioned the temporal lobe. Now we'll talk about the optic nerve, right? The optic nerve is cranial nerve 2. Let's see where that is. Optic nerve is CN2. This is good practice though for the lab too. And so they can mix together a little bit. So the optic nerve is really important. It's coming from the retina. Same thing, just delivering the information to the occipital lobe, which is here, right? This is the cerebellum. So again, remember that for lab. And then we're going to talk about the optic tract is behind the optic chiasm. You're going to learn about how a lot of things cross over in the brain. You're going to learn the word decussation, means cross over. So that's really important later when we do more physiology, but just get the names down now. So you can see part of the diencephalon, but you really can't see too much. So they have these little bumps here called the mammillary bodies. Mammillary bodies are really another thing that's involved in olfaction. Again, cognating that olfaction via the mammillary body. So it has something to do with smell as well. It's a lot of smell. Midbrain, you're going to find is more motor. And I got to talk about the posterior midbrain. I should say the superior midbrain in this case. Pons, right? Medulla oblongata are all parts of the midbrain. So right now, the question I'm going to ask you is, what are the three parts of the midbrain? I'm sorry, the brainstem. And you'll tell me midbrain, pons, and medulla oblongata. And then, diencephalon was the hypothalamus, thalamus, and epithalamus, which was really important for now. At least get to learn it. And then the lobes of the cranium, of the cerebrum. Basically what cranial nerves are. And cranial nerves we kind of talked about at the beginning. They're peripheral nerves, right? The peripheral nerves, all these are cranial nerves, there's 12 of them, and they're paired. But they have nuclei inside the brainstem mostly, except for these two, like olfactory nerve and the optic nerve do not have nuclei in the brainstem. They're more frontal. So those kind of things, just to get an idea, very simple for this. I'll give you some study questions that will help you with the intro to the brain. This is the mid-sagittal. Now you can see more things, right? You can see that this is the gyrus, sulcus. Here's the central sulcus, which is really hard to point out. I would even in the lab, I would never ask you unless this was clear to where these were. And this is an important structure. This is what connects the left and right hemispheres of the cerebrum. That's called the corpus callosum. So this is called a commissure. Let's get used to some of these words. Commissure is a connection between two parts of the cerebrum. In this case, it's two different hemispheres, right and left. So it connects left and right. Corpus callosum. And it's not connective tissue. This is neurons in this part. So again, you'll do this in lab, but I need you to know that that's a commissure. That's a connection. Here's the parts of the diencephalon, right? The epithalamus, thalamus, and hypothalamus, like I just said. You could see, here's a good thing here. You see in the cerebellum, you have this like tree of life, right? It looks like a tree, the white matter. And the white matter is called the arbor vitae. So just put that, it's always something that's always going to be asked on the test, like lecture and lab. The arbor, is it spelled right? Arbor vitae, like tree of life, is the white matter of the cerebellum only. So it's myelinated fibers, axons. And the gray matter is everything else. So you can't see that here yet, but we'll get to a slide that shows you that. So just do a good introduction today so you get used to seeing this thing. Here's the hypothalamus, which is really controls a lot in our body homeostatically. This is the pituitary gland, which is not nerve tissue. It's endocrine tissue. Let's see, that shows you the pineal gland here too, which is kind of right there off the epithalamus. So this is a good start. Just go through these because this is very helpful for the rest of the semester, just to see where everything is. And sometimes it helps you with the physiology too. Here's the midbrain. And this is both the midbrain, the back of the midbrain and the front of the midbrain. So this is all midbrain. This is the pons, which has like a bulbous front there, more towards the anterior. Here's your medulla oblongata. Then you have your foramen magnum, and below the foramen magnum starts the spinal cord. And you have your first cervical nerves, spinal nerves. emanating from there. And it's still, remember, the brain and the spinal cord are CNS, which are just two things. And everything else that's not the brain and spinal cord is considered peripheral nervous system. So this is some clinical views, and we should talk about these. And then later, when we talk about other parts of the brain and their physiology, this kind of makes sense because you can relate this, right? You've probably heard of traumatic brain injury, right? Acute brain, it means it just happened. Acute versus chronic, and it's traumatic. So it could be you fell or you got hit. Boxers have to deal with this all the time. Football players have to deal with this all the time. So concussion is an example of a TBI. And it's hard to really quantitate a concussion. Like you can't see anything on an X-ray or MRI or ultrasound or PET scan, all that. You really can't see. So it's based on these symptoms like, dizziness, loss of consciousness or semi-loss of consciousness, pain, confusion. Amnesia means lack of memory. That's possible. So this is the scary thing with concussions, their cumulative effect. Because once you injure brain tissue, like endoglial cells, that doesn't really regenerate neurons. Like the PNS is much more regenerative than the CNS, like the brain. So the cumulative effect is if you have one concussion and then 3 weeks later you get another one, that just multiplies the effect. So if you're a soccer player and you bump heads with somebody and have a concussion, you're not back on the field for at least 2 weeks until some of these impact testing gets less. Now, if you go back to practice too soon, you start doing headers even if you're doing them correctly, you're going to add to the effects of this concussion. So concussion is a traumatic injury that creates this syndrome, causes an impact. So it could also affect your thinking, right? So you need to rest your brain, just like a muscle would be rested. You can't tax the brain by going to school even post-concussion, right? Even taking tests is not a good idea within a couple of weeks of concussion. And it can lead to changes in certain chemicals that are released in your brain that could affect your mood, like serotonin, or your personality may affect your dopamine releases. Change who you are, right? Intellectually and personality. Now, bruising, contusion, is basically, now that this is going to involve some broken blood vessels. And broken blood vessels are basically called a hematoma. So a hematoma is like a pooling of blood within the coverings of the brain, which we could talk about too, hopefully today if we can get to it. So hematoma means blood pooling in the brain, like a brain hematoma. Like subdural, you might have heard of epidural hematomas, things like that. And before, by next lecture, you'll understand what the dura is and what subdural and epidural means. So just going to introduce some of this brain stuff. Second impact syndrome, of course, that before the first one resolves, you're going to have some more physical problems. Now, if your brain could swell, and like a hematoma, you could see on it, possibly on an X-ray and definitely on a CAT scan. Swelling, you could probably see on an MRI or CAT scan as well.
Excuse me, sir?
Yes.
How would I get rid of one?
Rid of a hematoma?
Yeah.
A hematoma, now it depends on which one it is, right? Some layers of the brain are tend to bleed more than others. So it depends. If you have a fracture, I mean, you can't really, do anything for a fractured skull except let it heal, of course. It depends on the extent of the damage. But they do what's called cauterization, which basically stops the blood or the blood vessels from leaking and creating more swelling. So that's really the only thing they can basically do. And
I had one on my hand. I had one since like maybe like August. I mean, not August, since October.
Uh-huh. You had a hematoma?
I still got it. It
Yeah.
just healed, it just healed like this. It was
Yeah, I mean, it's self-limiting to a certain way. It depends on how bad it is, and sometimes they can't even see it, and they'll just call it a hematoma because they figure that's happening. But did you have a CAT scan?
Nah, I was supposed to go in for something, but I just wanted to like
Yeah,
wait.
you go for a CAT scan, and then they'll see if there's still blood in there. And sometimes this is why it's really important that you maybe get a CAT scan, because it depends on where the hematoma is. Like it's certain layers of your brain, your blood vessels are more vulnerable to keep bleeding, so it could make it worse. So they have to find out where it is. Is it subdural? Is it epidural hematoma or subarachnoid? There's different layers, which I'll show you. So most of the time, yeah, it's self-limiting, and you'll see this, like, say later on, somebody has a brain injury or has a symptom that calls for an MRI or a CAT scan. Sometimes they'll just do a CAT scan. They'll see like the hematoma that was from 10 years ago. So technically that's a TBI. It isn't. It's not technically, for sure. That's a TBI that has to be treated like a first impact injury. So be really careful, about another head injury, because that would, create an impact, a second impact, which would create more problems.
What's the difference between CTE and TBI, if there is one, besides it being
Well, a CTI is chronic, right? Or TBI is acute. That's the main difference. So a CTE is chronic traumatic encephalopathy. Like, so you're an MMA fighter and you're constantly getting it done, and you're having impacts over and over. That's going to create really ongoing problems like this. So the difference is the acute versus chronic. Acute is maybe a one-time, just happened. Chronic is a repetitive, over time injuries, right? Like a boxer, MMA, a soldier, somebody a victim of abuse, right? You understand that, Renee?
Yeah, but all right, so acute just means like it happened one off time, right?
Or just recently, yeah.
So can you recover from the non-acute, or once
No, that's really hard.
it's like that's it?
That's really hard. That's a really tough condition, CTE. That's the one that has us confused, how to treat it, right? So I'll get into that when we talk about the limbic system and post-traumatic stress.
Okay.
Yeah, right. That sounds familiar. Right? So development of the brain and its divisions. I'm not going to go into this too deeply, right? So the notochord is one of the early beginning of the brain and spinal cord. The notochord. The relation is just development of the nervous system. So it begins really early, third week, right? Right, Renee? This is like 3 weeks after that Friday night.
Yeah, can't wait.
Yeah, it's like 3 weeks after that. So, your nervous system developing, and then your heart starts beating, and then your bone starts developing. So it's really important that the nervous system gets a good start, as far as that goes. So I'm not going to go too much into the relation and development of anything, because we don't have time for that. We have to really get to the nuts and bolts of this. So we know what gray and white matter is now, right? White matter is your myelinated fibers or axons. Gray matter, not so much, no myelin. So that's your cell bodies, right? Or unmyelinated axons. So cell bodies usually have dendrites, depending on the type of neuron. So this cortex is the outer, superficial layer, especially of the cerebrum. And that's gray matter. The cerebral cortex is gray matter. It's not myelinated cell bodies. So where all the organelles are for most of the organelles for a neuron. Now, nucleus are groups of cell bodies in the CNS. So nucleus are only in the CNS. Because in the PNS, cell bodies are called ganglia, or ganglion is one. Ganglia is plural. And white matter consists of myelinated fibers. We know that. This is a nice frontal section of the cerebrum, mostly. So you could see all the white matter in here, which consists of myelination, white axons. And this is the cerebral cortex. It's the outer part. So if this is the parietal lobe, this would all be your primary somatosensory area in the postcentral gyrus. And down here you have your temporal lobe, temporal cortex, where you cognate smell and hearing. And this you can learn, like, well, first of all, this is the corpus callosum from a frontal view. This is the connection between, and this would be your left hemisphere, this would be your right hemisphere. And the corpus callosum is a commissural area, which fibers are crossing over. It's not connective tissue, right? And in here, this is space. I want to tell you what this is now. There's like spaces in the deep in the brain, and these are called ventricles. Like this is a ventricle here too, and that contains a fluid called cerebrospinal fluid, or CSF. So CSF function is really protection of brain tissue, because it also flows down through the spinal cord as well, which you'll see, and also around the brain. That's when we talk about CSF. And this is right here is basically part of the diencephalon, the thalamus. You're going to see. So you don't have to worry about that on this picture. Right here, this is all I'm telling you is what the cerebral cortex is. Oh, and there's a fissure right in the middle between this, which wasn't mentioned before. So a fissure that separates the left and right hemisphere above the corpus callosum is called a longitudinal fissure. Very nice. So you'll see that, and that just in words separates the two, the space that separates the two hemispheres, but the corpus callosum connects them. So just get a good idea of what this looks like and to get used to the terms. That's what this is about today. This is a different view. Not really much to tell you here. You know, again, you know, the cutting through here, you're looking down. So again, you can see white matter of the cerebellum, and you can see some gray matter of the cerebellum. So this is lower in the brainstem. And if you notice, the brainstem is anterior to the cerebellum. That's important, just so you have those ideas of what's going on. So this is just, again, just showing you different slices. This is a slice, like if you look down at the spinal cord. So this is the spinal cord here, and this is the medulla oblongata. So you can see that the inner part forms like that under armor H, and that's gray matter. Everything else is white matter, myelinated in the spinal cord going up and down. This is the medulla oblongata, which has many nuclei for cranial nerves. And the gray matter is nuclei, which is groups of cell bodies in the CNS. And the medulla oblongata is the brain. It is CNS. So you can see white matter spread out through there, and that's myelinated axons. So these are the coverings. I'd like to do this today because this is a good, and this brings up good questions too, like who was asking about subdural hematomas and stuff. So the coverings of the brain and spinal cord, really, of CNS, are called meninges. And these are the brain meninges, or the cranial meninges, right? So there's 3 layers. This is the deepest one, the one that covers the brain tightly, right? And then the next outward, going towards the bone, is arachnoid matter. And then the next one, the outermost layer of meninges of the brain, is called the dura mater. And dura mater means, I think it actually means tough mother. Tough mother. like Claudia. She's a tough mother. So that's the outermost. And there's two layers of dura mater. You have the outermost is called the periosteal layer or dura. And you have meningeal dura. This is only in the brain. Maybe we get a picture, go through the arachnoid, and we'll go through these next time, like more specifically. So here's the bone, right? Here's the skin that you go through, and then you have the covering of the bone called periosteum. Then you have the bone, the cranial bones. And the outermost is the dura. The pia is the thin one right on the brain tissue, and the arachnoid's in the middle. So those are kind of, and they all have functions that we're going to talk about, you know, like as far as containing the cerebrospinal fluid, or the ones that have more blood vessels, the one that's injured certain times. So we'll go through different things, but we're running out of time, right?